So this is our third lecture today, and in last lecture we got to the understanding about the basics of electrophysiology of heart and the basic mechanisms of development of arrhythmias. Today we will be focusing upon how to approach arrhythmia with respect to ECGs, how to diagnose an arrhythmia. When you look towards an ECG, what are the characteristics of that arrhythmia, what are the basic principles of management of that arrhythmia, and what are the long-term management principles. So I'll just recapitulate few things from the last lecture that we need to understand. Basically, when we talk of Brady arrhythmias, two things. One is decreased automaticity and conduction block. And in tachyarrhythmias, we have increased automaticity trigger activity, which is of two types: early after depolarization and delayed after depolarization, and lastly re-entrant circuits. In decreased automaticity, we had hypothermia, increased TSH, increased vagal tone, inferior wall MI, increased potassium, beta blockers, calcium channel blockers, right? In conduction block, we had Lyme's disease, we had fibrosis, we had inferior wall MI, again potassium. Similarly, in tachyarrhythmias, increased automaticity, whenever you have increased epinephrine drive, right? You have fever, thyrotoxicosis. In trigger activity, we had two phenomena, EAD and DAD, right? In EAD, this was a major phenomena for VTAC, which is polymorphic with increased QT interval. Three electrolytes which were implicated were potassium, calcium and magnesium, and there were certain prerequisites as antiarrhythmic drugs class 1A, 1C and 3, antibiotics such as clarithromycin, you have barbiturates, you have tricyclic antidepressants, ondansetron, right? Then in delayed after depolarization, we had ischemia, dilated cardiomyopathy, mitral regurgitation, etc. Right? So these were the basis of development of arrhythmias. So we'll start with Brady arrhythmias first. So we have a normal ECG in which we have a P wave, the duration is 0.11 second. We have PR interval. PR interval is from the beginning of P wave to the beginning of QRS. From the end of P wave to the beginning of QRS is PR segment. P wave plus PR segment is PR interval. So this is 0.1 to 0.20 seconds. QRS duration is 3 small squares, that is 0.12 second, and QTC interval from the Q wave to the end of T wave, this is QTC. This is taken as 500 milliseconds. However, it varies with heart rate. So these are the normal times you need to always remember. So if we talk of Brady arrhythmias, the first thing would be that the heart rate would be less than 60 as a rule. A Brady arrhythmia cannot have a heart rate which is more than 60. It has to be less than 60, right? Now you see PR interval. If PR interval is prolonged, and RR interval is equal or not varying, the condition is known as first degree AV block or first degree heart block, right? We are talking of problems at AV node, right? It can be sinus bradycardia also. If the sinus node is not firing at 60 beats per minute, then it will be sinus bradycardia, right? In sinus bradycardia, your PR interval will not be prolonged. It will be between 0.12 to 0.20 seconds. RR interval will be fixed. It won't vary with beat to beat. So that would be sinus bradycardia. Suppose you have sinus bradycardia with sinus tachycardia, then it will be Brady tachy syndrome, right? Known as sick sinus syndrome. So you have certain problems at sinus node itself. But the more important aspect is AV node, right? If there is a problem in the AV node, the PR interval is prolonged beyond 0.20 seconds, RR interval is equal and it is not varying from beat to beat. This is known as first degree AV block. Now we have second degree AV block. In second degree AV block, what can happen is there are two types. In first type, you have gradual increase in the PR interval and a beat drops. Then again there is a gradual increase in the PR interval and a beat drops. So RR interval will vary from beat to beat. So there is gradual increase in PR interval and 1 QRS then drops. So prolonged drop. This is known as Vanke-Back phenomena. Right? This is Mobitz type 1. Mobitz type 1. What is Mobitz type 2? In this, there is no gradual prolongation of PR interval. PR remains normal, but there is suddenly one beat is not transmitted. So there is a focal block, right? So RR interval does not vary from beat to beat, but there is a sudden loss of transmission of one P wave from AV node to myocardium, LV myocardium, right? So this is known as Mobitz type 2 block. So it can be say like this: you have a P wave, you have a QRS, you have a P wave, you have a QRS, then you have a P wave, no QRS, again a P wave, then a QRS. It will be like this, right? This will be Mobitz type 2 block. It can be in a fixed ratio. It can be 2:1, it can be 3:1, it can be 4:1, 5:1, right? So you can have 5 normal followed by 1 drop beat, 5 normal followed by 1 drop beat, right? And lastly, we have third degree AV block. What has happened is that AV node is not transmitting any impulse from atria to ventricle. So what will happen is ventricular pacemaker will take over because it has to survive. The ventricular pacemaker can be in the bundle of His, it can be in the bundle branches, it can be in the Purkinje fibers, it can be in the myocardium itself. So the rate is usually somewhere around 40 beats per minute. It can be lesser also, right? So at 40, it is compatible with cerebral circulation. But the moment it drops below 40, patient can experience syncope and loss of consciousness, right? So atria are beating at their own pace ventricles are beating at their own pace, there is no relation between P wave and QRS. So PR interval has no significance. None of the P wave is transmitted in the ventricular myocardium. So this is third degree heart block. So how do you deal with Brady arrhythmias? Mind you, type 1 or first degree AV block, type 2 Mobitz 1, they are generally benign. Hardly they cause any symptom because most of the beats are transmitted in the ventricular myocardium, so the cardiac output is preserved. Patient usually doesn't give any symptoms. Problem is with Mobitz 2 and third degree AV block. If a patient has third degree AV block, you require pacing. Now pacing can be transcutaneous or it can be transvenous. In transcutaneous, you put pads over the chest wall. It is painful for the patient. The moment the pacing apparatus sense that the beat is going down a certain threshold, it will give rise to a shock, right? And it will start pacing the ventricle. So it is painful. Transvenous, you put a catheter through the femoral artery, go to your right ventricle and then place the leads there, and that will give the shock to the ventricle to contract. Then you have to ascertain what is causing these blocks. There can be a situation which is causing these blocks. You can have patient who has taken high dose of beta blockers. Suppose someone is on metoprolol and inadvertently has taken 200 milligrams of metoprolol. He comes to you with third degree heart block. So what do? You give something to reverse it. So the drug to reverse beta blocker effect is glucagon. So if anyone has a third degree or a symptomatic heart block because of beta blockers, you give glucagon. Suppose someone has taken high dose of calcium channel blocker, verapamil, someone has taken for some other reason, right? High dose. So you give calcium, either calcium chloride or you give calcium gluconate to the patient. Someone can take digoxin for any reason. He may land up into a symptomatic high degree block. So you have antibodies, FAB, which works against digoxin. You can use that too. Suppose someone has Lyme's disease. Lyme's disease is not a disease of India, but suppose someone has Lyme's disease, Borrelia, right? So the treatment in this case would be ceftriaxone, right? So this is how you approach to Brady arrhythmias. It's very simple. In acute emergency settings, you can use atropine. What atropine will do? It will abolish the vagal tone on AV node. It will abolish the vagal tone on AV node. If vagal tone is abolished, what will happen? The sympathetic drive will overpace the AV node. So the block will go away. You can use epinephrine also. So anyone who lands up in emergency with symptomatic heart block, you can use atropine, you can use epinephrine, you can go with pacing, which can be transcutaneous, or you can do a transvenous pacing, or you can install a permanent pacemaker in such patients, right? I hope this is very clear. It's very easy. Brady arrhythmias, right? Now comes tachyarrhythmias. They are a bit tricky, so pay enough attention. There is an approach to tachyarrhythmias. The approach is like, once you have appreciated that heart rate on ECG is more than 100, it means you are dealing with some tachyarrhythmia. Now what do? You decide by seeing the QRS whether this tachyarrhythmia is narrow complex tachyarrhythmia, that is the QRS is less than 0.12 seconds, or it is wide complex tachyarrhythmia. This is the first step, more than 0.12 second. Right? First step in tachyarrhythmia is you see the QRS, whether this QRS is narrow or wide. Then you see, by putting a piece of paper, you measure the RR interval. You know how to measure RR interval? By putting a piece of paper, you mark 3 complexes and you then push that paper across the ECG line. Thereby you can measure the RR interval. So then you see whether these are regular or irregular. Similarly, wide complex, regular or irregular. This is the algorithm by which you will come to the conclusion which arrhythmia you are dealing with. Otherwise, it is practically impossible to approach a tachyarrhythmia, particularly when we are dealing with difficult tachyarrhythmias such as SVT with aberrancy or bundle branch blocks and so on and so forth. So you have to decide whether your complexes, QRS complexes, are narrow or wide, and whether they are regular or irregular, right? So first we talk about narrow complex. Narrow complex. That means QRS duration is less than 0.12 seconds. It can be regular, that is your RR interval does not change, or it is irregular, that is RR interval changes, right? So the best example of regular narrow complex tachycardia would be sinus tachycardia. Am I correct? Sinus tachycardia is the simplest and the best example of regular narrow complex tachycardia. How we identify sinus tachycardia? We identify it by looking at P waves. We have to know that this is sinus tachycardia, not some other type of tachycardia. So how do you know? You see P waves in lead 2, lead 3, lead AVF and V1. They should be upright. They should be upright in lead 2, 3, AVF in V1, and they should be inverted in lead AVR. Right? P waves which are upright in lead 2, 3, AVF and V1 and inverted in AVR, each P wave is followed by QRS. Each P wave is followed by QRS T. None of the P wave is without QRS T. So this is your sinus rhythm, right? So this is your sinus tachycardia. The rate is more than 100. Your P wave is upright in your inferior end leads and V1, and you have a inverted P wave in AVR, and each P wave is followed by QRST. This is your sinus tachycardia. Then comes focal atrial tachycardia, FAT. By focal, what does it mean? That suppose this is your heart, this is your SA node, this is your AV node. So the transmission of impulse is from up towards down and left. Now what happens is SA node is not functional because of some problem. So there is a ectopic pacemaker. Say here you have a pacemaker, new atrial cell has taken over the SA node. So it will start spreading the impulse, but the impulse spread will be like this. So the vector would be pointing away from the positive electrode of lead 2. So what will happen is P wave becomes negative in lead 2, 3, AVF and V1. This is because of the orientation of the lead of that electrode, right? So you have negative P wave in 2, 3, AVF and V1, and what will happen in AVR? AVR is here, right? So it will look as positive. So your P wave becomes positive in AVR. So this is known as focal atrial tachycardia. Each P wave is followed by QRST because that P wave will be transmitted from AV node through bundle of His and into the ventricular myocardium. So FAT means negative P wave in lead 2, 3, AVF and V1, and positive P wave in lead 2. The morphology of P wave is identical because focus is one. You have only single focus. If there are multiple focus, then it will become multifocal atrial tachycardia. So this is a single focus. PR interval can be shortened because this P can be near to AV node, right? So PR interval can be shortened depending upon the distance of a new pacemaker from your AV node. So this is known as focal atrial tachycardia. Then you have SVT, supraventricular tachycardia. This is of two types, AVNRT and AVRT. See, if you go deep into the genesis of AVNRT and AVRT, you can appreciate on ECG whether you are dealing with AVRT or AVNRT, but practically it doesn't matter because treatment is entirely same, right? So when we are talking of SVT, we are talking of AVNRT and AVRT simultaneously. So how do you identify? How do you identify? You identify that you cannot see P wave. You will not be able to see P wave, but this P wave can be appreciated where? Suppose it is like this. There can be a slight slur in the downstroke of QRS. Something like this, slight a slurring of QRS after it, because see, SVT, the mechanism of SVT is reentrant circuit in the AV node. So one beat will be transmitting towards your ventricle and one will go up simultaneously. The transmission in the ventricular system is fast, so QRS will be coming faster. Then you will have a reflection of P wave which is going upwards. So you can have a negative P wave or you can have a slurred stroke in the QRS, which is in fact P wave. Very difficult to identify in ECG, but you can. So how do you differentiate? If suppose you have identified P wave, you can differentiate whether you are dealing with AVNRT and AVRT. What's happening in AVNRT and what's happening in AVRT? Here the problem is at AV node, and here we have accessory pathway somewhere else. You have accessory pathway somewhere else, right? Here the problem is in AV node. So in AVNRT, the P wave is either inverted or it is in the QRS complex itself as a slight slurring, which you may appreciate. But in AVRT, you can have P wave like this, QRS, a P wave which is just besides T wave. See here, this, you can have a QRS P wave and T wave, this P wave. So you can have a P wave on T wave, you can have P wave which is, you know, just besides T wave, and the RP interval is generally 70 milliseconds or more. You got the point? In AV and RT, either you won't see P wave, or if you are able to see P wave, they would be inverted just after QRS, or they are merged in QRS. But in AV/RT, you can find a P wave as a slight upstroke at the start of T wave or on the T wave, and the RP interval will be 70 milliseconds or more. Right? Clear? And the last would be atrial flutter. So you have sinus tachycardia, clear. We have focal atrial tachycardia, which is clear. We have SVT, which is cleared, and which is last is atrial flutter. What's happening in atrial flutter? That you will have sawtooth waves like this. This is lead 2. So if you see lead 2, you will have sawtooth waves. They will be negative. Why it is negative? You know, there is a isthmus, cavo-tricuspid isthmus here near your tricuspid valve. So the current in that isthmus is counterclockwise like this. Cavo-tricuspid isthmus, the current flows in a counterclockwise direction. Because of this counterclockwise flow, when current is going like up, your 2-3 AVF will capture it as negative wave, negative P wave. It's going up like this, away from 2-3 AVF, counterclockwise current, right? So you have negative P waves, which are sawtooth waves in 2-3 AVF, and in V1 you have positive sawtooth waves like this. Suppose the current is clockwise. Suppose there is a variant of atrial flutter where the current in the caverno-tricuspid isthmus is clockwise. Then you will have positive flutter waves in 2-3 AVF and negative flutter waves in V1. Clear? In flutter, there is always a fixed ratio. Here we have 3:1. Means there are 3 P waves and 1 is transmitted. Then 3 P waves, 1 is transmitted. You can have 4 P waves, 1 will transmit. 4 P waves, 1 will transmit. Right? You can have 1:1. You can have 2:1. You can have any ratio. But the ratio is fixed. So this is atrial flutter. If the ratio changes, then it becomes atrial flutter with varying block. At one point you have 2:1 ratio, sometimes then it becomes 8:1 ratio, then it becomes varying block. Got the point? You know, simple tachycardias, which can be sinus tachycardia, usually generally heart rate doesn't cross 150, right? But when we talk of tachycardias apart from sinus tachycardia, say for example SVT or focal atrial tachycardia, the rate can be somewhere between 150 to 250. If we are talking of flutter, the rate could be between 250 to 350. And when we talk of fibrillations, the rate is generally more than 350. This is arbitrary. You can have a tachycardia of 180 also, sinus tachycardia of 180, but generally tachycardias which are simple are less than 150. Any tachycardia which is not sinus tachycardia, such as FAT or SVT, the rate is 150 to 250. Flutter are 250 to 350. and fibrillation is more than 350, right? So how do you treat? Suppose you have sinus tachycardia in emergency. How do you treat? So we recapitulate from our last lecture what causes tachycardia. It's usually response to something. It can be response to hypovolemia. Patient can be bleeding. So you correct the problem. You correct hypovolemia. You correct the volume. Tachycardia will settle down, right? You correct the blood loss. Tachycardia will settle down. You correct the fever. Tachycardia will go away. You can have hypoxia, which is driving tachycardia. Give oxygen. You can have pulmonary embolism giving rise to tachycardia. So you treat. So you treat the cause. If you have anemia, treat the cause, right? Secondly, if you do any vagal maneuver, suppose you ask patient to strain as if he is going for poop, right? So when you strain, your vagal tone will increase. What will happen with the vagal tone? It will cause a block at AV node. So your tachycardia will settle down. Or you tell him to force air into a stiff balloon or something like that. So you do vagal maneuver, right? So that can cause suppression of these tachycardia. Suppose nothing works. So vagal maneuver you tried, it failed. So you use your basic drug. Say for example, you can go for adenosine. 6 milligram IV push, right? Adenosine suddenly blocks AV node completely. Not forever, but it transiently blocks AV node completely. So you can see your SVT goes away immediately. Your fat can go away immediately. Your atrial flutter may go away immediately. If it doesn't help, then you go for beta blockers. Don't hesitate in using metoprolol IV. People are hesitant in using IV beta blockers. It's readily available. You use it, right? Unless and until there is some specific contraindication. You have a symptomatic peripheral vascular disease, or you have a severe bronchial asthma. Otherwise, you use beta blocker. You use beta blocker, your adrenergic tone is blocked. So comparatively, your vagal tone is high then, right? So it affects your SA node also, it affects your AV node also. And then you use calcium channel blockers if that doesn't work. Or if there is a contraindication to beta blocker, you use calcium channel, you use IV diltiazem, you use IV verapamil, right? You can use digoxin. Digoxin is vagotonic, right? It increases your vagal tone. It doesn't act directly on AV node, it increases your vagal tone. So increase in vagal tone will decrease the conduction at AV node. So you have A, B, C, D. These are known as ABCD drugs. Adenosine, beta blocker, calcium channel blocker, and digoxin. They help to control rate at AV node. Suppose nothing works, and patient starts having chest pain. They have got hypotension now. They have pulmonary edema, or they are unconscious. They lose their consciousness. You cardio word them. You cardio word them. There is a fine difference between defibrillation and cardioversion. Okay, there's a fine difference. Cardioversion means you are cardioverting the rhythm into normal sinus rhythm, but the cardioversion is synchronized. Okay, what is synchronization? That at the upstroke, this R point, this inflection point will be captured by your paddles, and the delivery of current will be exactly here. So just remember this thing. Most of the tachycardias, be it supraventricular or be it ventricular, apart from ventricular fibrillation, most of the tachycardias are cardioverted. Ventricular fibrillation is defibrillated, right? So you Follow now sinus tachycardia, that you have upright P waves in 2-3 AVF, negative P wave in AVR. Every P wave is followed by QRST. This is sinus tachycardia. Rate is less than 150. Focal atrial tachycardia, there is a single focus elsewhere than SA node. It is negative in 2-3 AVF, followed by QRST. PR interval may be shortened because this ectopic node will be nearer to AV node. Then you have SVT, wherein P wave finding will be very difficult. If you find, there can be two things. In AV and RT, the P wave would be either merged in QRS by a slur like this, or it can be just after QRS like a negative P wave. Why negative? Because it is going up from that loop, it is going up. So your 2-3 AVF will capture something going up, right? In AV-RT, the accessory pathway is somewhere else. So you can have a P wave here or here. You can have a P wave and the RP distance would be 70 milliseconds or more. Then you have atrial flutter. The current is counterclockwise, and that is the reason you have negative flutter waves in 2-3 AVF and a positive flutter wave in V1. If the current is clockwise, opposite happens. You have positive flutter waves in 2-3 AVF and negative flutter waves in V1. Treatment is very simple, right? Now we come to narrow QRS tachyarrhythmia, which is irregular. Narrow QRS tachyarrhythmia, which is irregular. So first would be atrial fibrillation, right? First would be atrial fibrillation. Then you have atrial flutter with varying block. And third would be multifocal atrial tachycardia. Atrial fibrillation, atrial flutter, and multifocal atrial tachycardia. Now, how do you identify atrial fibrillation? What's happening in atrial fibrillation? There are hundreds of focus in your atria. Each one is generating their own vector, haphazard, distributed vectors. So what will happen is the voltage of P wave will be very less, because there is no net vector, right? There are hundreds of atrial cells which are producing their own current, so they are undulating. So you have a baseline which is undulating like this. Something like this. What is happening is you are having hundreds of P waves, but none of them are powerful enough to give rise to a P wave of 2.5 millivolt amplitude. So they are giving you some P wave, but they are so minuscule that the baseline is just undulating. So these is known as fibrillation waves. Okay. Flutter we always denote as capital F waves. Fibrillation we denote as small f. Fibrillation waves. Okay. Now just imagine that there is a bundle of Kent here, right? I have atrial fibrillation and I have a bundle of Kent, and you gave me adenosine. What will happen? Just imagine. This is a very vague thing to think. Something was being conducted through AV node. The ventricular rate is suppose 100. So 350 rate is atrial, 100 is ventricular. That means out of 350 atrial beat, 100 were transmitted by AV node. AV node is holding, otherwise everything will go down. Now I have a bundle of Kent here, an accessory pathway which is unregulated, and someone gave me beta blocker considering that I have atrial fibrillation. What will happen? My AV node will be blocked. Everything will be transmitted through bundle of Kent, and I will have ventricular fibrillation. So that is why it is very important, by looking at ECG, whether you are dealing with atrial fibrillation alone or you are dealing with atrial fibrillation with an aberrant pathway, like atrial fibrillation with Wolff-Parkinson's White syndrome, right? In those circumstances, these ABCD drugs which we discussed are absolutely contraindicated. You will convert a benign rhythm into a malignant rhythm, right? Whenever you have a pre-excitation of AF with, say, bundle of Kent on some accessory pathway, don't block AV node at all, right? We'll come to this, but it was just an example which I was giving. So, atrial fibrillation, your RR interval will vary because AV node will transmit randomly few of the P waves. So, there is no fixed way in which RR interval varies, it's a random way. So, the rhythm is irregularly irregular and there is fibrillation waves, correct? Now, you have atrial flutter with varying block. Again, the same thing, that you have negative sawtooth wave, P wave, then you have a QRS, negative sawtooth wave, then a QRS, negative sawtooth wave, then a QRS. So, here the ratio is 3:1, 1:1, 4:1. So, ratio is changing. So, you see the RR interval is changing, it's getting irregular. But it is narrow complex because this P wave is transmitted by AV node. So, your QRS is normal, right? So, this is a varying block. You have 3:1, 1:1, 4:1, it can be 8:1, it can be 10:1, whatever. The combination will vary. So, this is simple atrial flutter with varying block, right? QRS will be narrow. Lastly, you have multifocal atrial tachycardia. So, what will happen is, suppose this is a normal morphology P wave, you have QRS, you have T wave, next P wave morphology changes, then you have QRS, then you have T wave, then again the morphology changes, QRS, T wave, then again morphology changes, QRS, T wave. So, if you have 3 or more different type of morphologies of P wave in a single ECG, it is multifocal atrial tachycardia. 3 or more morphology of P wave in one ECG, it is multifocal. So, what is happening is, there are again multiple foci in the atria. Few of them will be nearer to AV node, few of them will be further away from AV node, and that is the reason you will have varying interval, right? Some will be transmitted fast, some will be transmitted slow because it's farther away from AV node. So, your RR will vary, but it is the P wave which is being transmitted. It is the P wave which is being transmitted through a normal conducting system. So, the QRS will be narrow, correct? So, for regular narrow complex, we have sinus tachycardia, focal atrial tachycardia, atrial flutter, and lastly, yes, SVT, okay, sinus tachycardia, focal atrial tachycardia, atrial flutter, and SVT. Just remember these four in regular narrow complex tachycardia. In irregular narrow complex tachycardia, you have 3: atrial fibrillation, atrial flutter with varying block, and multifocal atrial tachycardia. So, how do you treat now? Atrial fibrillation, atrial flutter with varying block, and multifocal atrial tachycardia. You know, if we talk of MAT generally is due to some underlying disease. Most of the times it is because of the delayed after depolarization, DAD. In delayed after depolarization, ischemia, hypoxia, some structural heart problem are causative factors for MAT. So, whenever you have MAT, see whether the patient has COPD or not, see whether the patient is hypoxic or not, see whether the patient has pulmonary embolism or not. So, you treat those factors, this MAT will go away generally. So in general, what do? You try vagal maneuvers, suppose. Generally they won't work in any of these. You may try giving adenosine also, right? It may work in certain situations, but generally it won't. So once you have identified that patient has a narrow complex tachycardia, but it is irregular, the RR interval is varying, right? You generally don't use vagal maneuvers, you generally don't use adenosines. So what you use is, you use beta blockers, or you use calcium channel blockers, or you use digoxin, right? Again, you cardiovert if you have a hypotension, you have chest pain, you have syncopal attack, you have pulmonary edema. So don't wait for these drugs, simply cardiovert. You don't have to use very high joules, even a 60 joule cardioversion is enough to terminate these supraventricular arrhythmias, right? I hope this part is clear now. Narrow complex, regular and irregular rhythm. So in both of the cases, what are the long-term strategies? Suppose you have an SVT, you have a AV-NRT. So for symptomatic relief, you can put a patient on long-term beta blockers, you can put a patient on long-term calcium channel blockers, but what is the final treatment? The final treatment in any of these conditions would be radio frequency ablation. You do electrical mapping of the heart, find the circuit, reentrant circuit, or the foci which is, generating the extra impulse, and you burn them with radio frequency. That is the final treatment for these type of supraventricular tachyarrhythmias. Now we come to slightly difficult aspect, that we are dealing with not narrow complex, but we are dealing with wide complex, which is more than 0.12 seconds. Okay, wide complex, that is QRS is now wide. Again, it can be regular or it can be irregular. So what is regular? Ventricular tachycardia, which is monomorphic. Is regular, but it is wide. SVT with aberrancy or a bundle branch block, is one and the same thing, is regular wide complex. You remember last time we talked about orthodromic and antidromic AVRT? When the current passes from AV node, goes through bundle of Kent up, this is known as orthodromic AVRT. The QRS complex will be normal because the conduction is to the normal conducting system. Suppose the current passes from the bundle of Kent to the ventricle and then it goes up, so QRS will widen. So this is known as antidromic AVRT. So these are the three conditions. See, there can be a possibility that you are unable to identify any of this. So my sincere submission is that in ECG, in your exam, just identify that, sir, I have a wide complex regular tachycardia. These are the three differentials. That will fetch you enough marks. Don't go into the details. If you are unable to understand, if you are unable to remember, I'll tell you the finer points, but if you are unable to remember that what is the difference between ventricular tachycardia, which is monomorphic, versus SVT with aberrancy, no problem. But you should be able to identify in your ECG whether my QRS is wide or my RR interval is wide. This is simple. Anyone can identify this. So if you are able to identify your QRS is as more than 0.12 second and it is regular, you have a differential diagnosis of these three. This you have to remember. If you can't, it's okay. Now, how to differentiate? The most important thing is VTach and SVT with aberrancy. See, what's happening is, I'll show you an ECG. See, I hope you are able to see this. I hope you are able to see this. Let's look the morphology. Is it same? Exactly same morphology. This is a QRS. See how wide it is. How wide it is. Must be somewhere around 0.16 second. Right? Can you see lead 1? Everything is negative. And can you see lead AVF? Everything is negative. So negative in lead 1 and negative in lead AVF means extreme right axis deviation. Yes or no? So you have a tachycardia in which QRS is wide, the morphology is exactly same, and you have extreme right axis deviation. This is a monomorphic VT. So how to differentiate? In monomorphic VT, the QRS is more than 0.14 seconds, whereas in SVT with aberrancy it is less than 0.14 seconds. Everything is above 0.12, but in SVT with aberrancy it will be less than 0.14. In VTach, which is mono, they will look similar. SVT with aberrancy will also look like this. Now how to differentiate? You have to see the width of QRS. If it is more than 0.14, it favors VTach monomorphic. If it is less than 0.14, it favors SVT with aberrancy. If the axis on ECG, if you see lead 1 and AVF, they are favoring extreme right axis deviation. Extreme right axis deviation. It is VTach, which is monomorphic. If there is no right axis deviation, it is SVT with aberrancy. You usually don't find P waves in such type of ECG, but if you are able to see a P wave in the QRS segment like this, and you see a P wave here like this, this P wave which is there in the QRS segment is known as AV dissociation. This is not the AV dissociation which we talk of in respect to third degree heart block. This is some other AV dissociation. So if you are able to find a P wave in a QRS, which in this context is known as AV dissociation, this favors VTach, AV dissociation. But in SVT with aberrancy, there is no AV dissociation. Lastly, patient's age is more than 35 years and you have some sort of structural or ischemic heart disease for VTach. In SVT with aberrancy, the age is generally 35 years and there is usually no structural or no ischemic heart disease, right? So you will find a ECG where QRS is wide but it is regular. There is no P wave. Fast heart rate, say around 250, right? 250 is tachycardia, and you have QRS which is wide. So you at least have two differentials in your mind, that I am dealing with a monomorphic VTach or I am dealing with SVT with aberrancy. So how to differentiate? If the QRS is more than 0.14 second, it is VTach which is monomorphic. If the QRS is less than 0.14 second, it is SVT with aberrancy. If you have extreme right axis deviation, it is VTach monomorphic. If you have no right axis deviation, it is SVT with aberrancy. If you have, AV dissociation, which means presence of P wave somewhere in the QRS, it is VTach monomorphic. If you have no AV dissociation it is SVT with aberrancy. VTach generally occurs in more than 35 years of age, or who have some sort of structural heart problem or ischemic heart disease, whereas SVT with aberrancy can occur in a kid also, where there is some problem in the electrical circuits, right, with no structural heart problem, no ischemic heart disease. Fine. So this is a difficult thing to remember, but if you can remember this, this will pay you dividends definitely in your ECG exam. Now, how to treat? We are not going into antidromic AVRT. That's very rare. We are not going into that. If you have some interest, we can talk about that after the class. Now, how to treat? Suppose you have a stable patient of VTach monomorphic in your emergency. So the drug of choice is amiodarone or procainamide. Amiodarone or procainamide are the drug of choice in treatment of wide complex regular interval tachycardia. And long-term treatment again is either you go for radio frequency ablation, right? And mind you, once you revert VTach, always try to find the reason of VTach in that patient. Most of the time that's ischemia. So you can find some T wave abnormality, you can find ST segment depression or ST segment elevation. You can have tropi which are high. So always try to search, particularly in monomorphic VTach, whether there is some underlying ischemic insult was there or not. You may not find it in VTach ECG, right? You may not find in VTach ECG, but when the ECG gets reverted to normal, you can find some ischemic insult going on. The moment you have cardiovascular collapse, you have pulmonary edema, you have chest pain, you have CNS which is knocked out, you go for cardioversion immediately. Don't think of amiodarone and procainamide in that context. Suppose you have a patient who has recurrent VTach. You revert after 10 days again a VTach. You revert after 10 days again a VTach. So then you place a automatic implantable cardioversion defibrillator. AICD device has to be fitted in such patients. The moment it senses that patient is going into VTach, it gives a small shock and heart reverts to its natural rhythm. Now we come to wide complex tachycardia, where the rhythm is irregular. So the first tachycardia is polymorphic VTach. It is of two types, with normal QT interval and with prolonged QT interval, which is known as torsade points, right? Second would be atrial fibrillation with Wolff-Parkinson's White syndrome. Then third would be atrial fibrillation with aberrancy or a bundle branch block. And lastly, you have ventricular fibrillation. It's not very difficult to remember actually. Once you go through this format 3 or 4 times, you will be able to remember them very well. Polymorphic VTach with normal QT interval and with increased QT interval, atrial fibrillation with Wolff-Parkinson's White syndrome, atrial fibrillation with aberrancy, and VFib. Right? Polymorphic means different morphologies. So, as in this case, we have normal similar looking morphologies In a polymorphic VTach, the morphology will change. Some will be taller, some will be shorter. Some will be taller, some will be shorter. Some will be more wide, some will be less wide, right? But they will be more than 0.14 second. So the morphology of this QRS will be changing in the ECG. But how to calculate QT, whether it was normal or not? So you need to have an ECG wherein you can show QT prolongation. See, generally you have a patient whose ECG is there, which is available. In this ECG, if we see, there is QTC prolongation. Okay, it's difficult to see from so far, but there is a QTC prolongation, and here it is terminating. So see the morphology of QRS, going up and going down, 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 smaller than up. So this is a changing morphology, and you just see this. See how different it is. In this you have exactly similar morphology. Here you have different morphology. The heights are varying, right? And you have a QTC prolongation. So this is VTach with prolonged QT. This is TDP, torsade points. So how do you differentiate polymorphic VTach with a AFib which has a accessory pathway of WPW? That means AFib impulses are traveling through a different pathway. So QRS will widen. You're getting the point? If they are traveling through the AV system, bundle of his bundle branches, QRS will be normal QRS. Now they are traveling through an accessory pathway of WPW. So they will be widened, but the rate is high. Atrial fibrillation rate is somewhere around 350 or more, right? So if you compare polymorphic VTach with normal QT interval and with AFib with Wolff-Parkinson's-White syndrome, the rate will be higher in AFib as compared to polymorphic VTach. So if I have an ECG where we have wide QRS complexes and the rate is touching say 350, and the other ECG where the rate is somewhere around 180. So the 180 rate will not be AFib with WPW, it will be polymorphic VTach with normal QT interval. You're getting the point? Difficult. I'll just repeat it once again. Polymorphic VTach and AFib with WPW syndrome looks similar. It looks similar. The problem is with the rates. This is an atrial rhythm transmitted into the ventricles through an accessory pathway. VTach is not an atrial rhythm. It's a re-entrant circuit in the ventricle itself. Getting the point? So there is no accessory pathway which is involved. Getting the point? So ventricles have a ectopic foci which is giving rise to some impulse, then which travels in a different direction, giving rise to wide complex tachycardia. So this is VTach. In AFib you have a higher rates, atrial rates are higher than ventricular rates. So when you have a high rate in the ECG, it favors atrial fibrillation with WPW. It is difficult, but can be managed in exams. Now how do you differentiate AFib with aberrancy? See, what's happening is you have an atrial rate of say 350 and you have a bundle branch block. It's a block which is permanent. So the morphology will be same. It won't vary. You got the point? It's a very fine point that if you have a block in a way, you have only one other way to go. So the morphology will remain same. If there is a left bundle branch block, so morphology will be a blocked morphology. Getting the point? If my left bundle branch is blocked, all the electrical signal will pass through the right bundle branch. So the QRS morphology will be exactly same in all the complexes. It won't vary. So that is the way to differentiate AFib with aberrancy, AFib with WPW, and polymorphic VTAC with normal QT interval. In VFib, you don't have QRS. It is exactly like atrial undulation. So you have chaotic, something like this. It's a chaos. Ventricles are not contracting, they are undulating. Cardiac output is nil. So if you have a ECG where you don't find any QRS, you are unable to identify QRS morphology, start CPR fast. You have to start CPR, right? No other treatment. Patient goes otherwise, right? Now, how do you treat other? If you are dealing with polymorphic VT with normal QT interval, again your drug of choice is amiodarone or procainamide. Right? If the rhythm is malignant, you have hypotension, you have shock, you cardiovert. Suppose you have a polymorphic VTAC with prolonged QT interval. How do you treat? We discussed in the last lecture. We give MagSelf. It's an early EAD which is causing this. EAD, you have potassium, calcium, magnesium deficiency. You stacked give magnesium sulfate. That's the protocol. Till that time, see for your potassium. If you have hypokalemia, treat it. If you have any offending issues, you have ondansetron, you have barbiturates, you have tricyclic antidepressants, you have clarithromycin, right? You have antibiotics, you have antiarrhythmic agents, withdraw the drugs, right? You use MagSelf as a membrane stabilizer in polymorphic VTAC with prolonged QT interval, right? Lastly, in AFib with WPW, you just have to understand this fact that if we are dealing with AFib with WPW, we are not going to use ABCD drug. No adenosine, no beta blocker, no calcium channel blocker, no digoxin. You will convert a rhythm which is manageable to a rhythm which is unmanageable, right? You don't do it at all. Remember this. The other way of treating prolonged QT interval rhythm is you increase the heart rate. If you increase the heart rate, your QTC prolongation decreases. So it's known as overdrive pacing. You do overdrive pacing in a patient who has polymorphic VTAC with QT interval. Overdrive pacing. Or you use isoproterenol drug. So you use overdrive pacing or isoproterenol. This will increase your heart rate. Increase in heart rate will decrease your QTC prolongation, thereby decrease chances of turning a rhythm into torsade points. Right? One more thing, which is the last thing I wanted to tell you. When we are dealing with regular wide complex tachycardia, we had monomorphic VTAC and SVT with aberrancy, right, as our main differential. These were our main differentials in regular wide complex tachycardia. Suppose we are unable to differentiate while looking at ECG, we are not sure what it is. So how to treat? In SVT you use adenosine. In VTAC we use amiodarone and procainamide. Mind you, if you use adenosine in monomorphic VTAC, you lose the patient, right? So this is a very fine point for practical purpose, that if you are unable to differentiate that whether you are dealing with a VTAC which is monomorphic or SVT which is aberrant, treat treat VTAC. You won't do any harm, right? Giving adenosine in a monomorphic VTAC can be counterproductive. But if you are very sure that you are dealing with SVT with aberrancy, the treatment is adenosine, right? See, when you go in your textbooks or you search net, you can have maybe 10 or 20 more types of arrhythmias. You can have sinus arrest, you can have sinoatrial exit blocks, you can have many things. What we have done is, we have paid emphasis to the ECGs which we encounter in clinical practice. We encounter Brady arrhythmias. It's simple, but in tachyarrhythmias we need to focus on those ECG which are really helpful, right? So always follow the algorithm that whether your QRS complex is narrow or wide. This is the best way to learn it. Otherwise it becomes very difficult and very confusing. And whether the rhythm is regular or irregular. Regular or irregular. Right? In regular you have sinus tachycardia. Next, SVT. Next, atrial flutter. Next, fat, focal atrial tachycardia. Okay, sinus tachycardia, SAF, S2AF, SAF. Sinus tachycardia, SVT, atrial flutter, and focal atrial tachycardia. If you have irregular narrow complex, you have atrial fibrillation, you have multifocal atrial tachycardia, or you have atrial flutter with varying block. Varying block. Here you have monomorphic VTAC, SVT with aberrancy, or antidromic AVRT. Here you have polymorphic VTAC, which can be normal QT or prolonged QT, AFib with bundle branch block, AFib with WPW, and VFib. I have not found a better way to learn arrhythmias apart from this. Right, so we finish our lecture today and we'll try to cover some other aspects of cardiac arrhythmias and some remaining aspect of ECGs in our next lecture. Right, thank you so much.